Hey everyone. So my name is John Arthur. I am an internist at Wright Patterson Air Force Base in Dayton, Ohio, and welcome to the ACY Student Lecture Series. Today I'll be presenting you a very interesting topic, and this is a very common thing that every intern, including myself, was quite nervous about. So don't get burned at 2 a.m. Diagnostics every intern should know. Personally, for me, these were just pieces of advice that I wish I knew before I began specifically for my night shifts. So for our objectives today, the goal is for you to have increased confidence in managing common 2 a.m. clinical scenarios, recognize STEMIs on an EKG and how to differentiate from STEMI mimics, and lastly, apply a simplified chest X-ray and acid-base disorder framework for rapid night overnight interpretation. Now, of course, this isn't going to be encompassing all the things that you should know. However, these pieces of information, specifically STEMIs, X-rays, and acid-base disorders, where a diagnostic piece of information I find was crucial when starting, even prior to my start as a resident. So this was me, okay? This was me day one. This is my first night shift. I was excited, but I was just super nervous. Yes, I had my senior resident with me. However, I felt my safety blanket was gone, okay? I felt as that there's a situation where there's little staff. I was by myself and alone, when that's not really the case. If anything, the night shift is actually very memorable. I learned a lot, and actually, believe it or not, some of my best memories were from night shifts. But let's start off with, providing that extra safety blanket for you again. And how do you do that? Well, let's first start off with the 3 cardinal rules. Okay, so these are the 3 cardinal rules in general for anything, but specifically for night shifts. First and foremost, you are never truly alone. Okay, always, if you find any kind of uncertainty, escalate early. So I can attest, I'm an attending physician for my residency program, and I can easily say, attendings, when you sign up to volunteer your time for teaching residents, we are there to help you. We signed up for this. I'm okay with being woken up 2 a.m., 3 a.m., as long as, for instance, you are just wanting to care for the patient. It's all about safety first, right? And I will be never mad, nor any attending will ever be mad if you just to call us for a question. There's never a silly question. Second rule, trust but verify, okay? Yes, the ED, when you're admitting someone, might tell you, yes, we talked to the specialists. They're now consulted. They're going to see the patient in the morning. Or a nurse or some other staff provider will tell you, yes, this patient is actually completely fine. There's nothing wrong with them right now. However, that's good. You should always trust them. But remember, all in all, you are ultimately the responsible physician for this patient, and you should always put your eyes on them. And lastly, your job for nights is just to recognize danger, not have every answer. So what I mean by this is that night team is the defense team, okay? So your job is basically just to put out any fires that they come about. Otherwise, let people sleep, okay? The workup, that extended treatment plans, all that's for the morning. Let the patient sleep. And also let your staff and you yourself get some rest if need be. So let's start, okay? So the most notorious, we'll start off with the EKG, specifically with the STEMI. So let's say it's 2:13 in the morning, and someone comes in saying, hey doc, can you look at this EKG? All right, so before we go into the depths of this, of course, we're gonna be talking about STEMIs, but let's talk about some quick little rules that really help us determine, okay, is this truly a STEMI? So you've probably seen this a billion times, whether it's through textbooks, videos, lectures, etc. This basically just shows you the typical format of an EKG. However, the 2 points I actually just want to show you, and that's it, are just the first star to the left here. Let me put in my little pointer. It's your J point, okay? So this is the point where there's a change in inflection, okay? This is when the S wave changes ultimately into the ST segment, okay? And this is important because this is typically where you're gonna be measuring for your STEMI. And then secondly, being the TP interval, okay? Why? Because this is actually the isoelectric point. So what do I mean by isoelectric? It just means there's no electric activity. And ultimately, when you're trying to determine an elevation, you need to have a reference point, and that's the isoelectric point. So compare those two. So if you look for the TP interval, you have your baseline, and then from there, find that change in the direction of the wave, that's inflection point, and that's ultimately the J point. Okay, so here is something else that we all love, I'm sure, okay? So yes, you've probably seen this a billion times. I'm fortunate to say that this is something you're gonna have to memorize. Why? Because of 2 points. First and foremost, this actually allows you to determine where specifically what coronary artery is affected when there's an occlusion, okay? If you think about it, let's say the anterior septal, so this is V1 to V4, this shows about the LAD, okay? If it's the inferior, okay, so it's leads 2, 3, and AVF, you're thinking of the right coronary artery or the left circumflex. Either way, this gives you a specific region, okay? And lastly, more importantly, in my opinion, is this brings about the concept of what we call contiguous leads. So what is that? So contiguous leads are essentially, you have leads that are sequential with each other that are looking at the same region of the heart. So case in point, V1 or V2, V3 or V4, or when you're looking at lateral, V5 or V6. Anything that's still, they're looking anatomically at the heart and they're right next to each other. This is important because we use contiguous leads ultimately to determine, okay, is this a STEMI? So now criteria for STEMI, okay? So it is an ST segment elevation at the J point and greater than or equal to 2 contiguous leads, all right? So specifically the ST segment elevation is gonna be 1 millimeter, okay? The only exception to that is gonna be for leads V2 and V3, and that's determined more on age as well as sex, okay? For women, in those specific regions, it's 1.5 millimeters, so that's 1.5 small little boxes. And for men, if it's the age of under 40, it's going to be greater than equal to 2.5 boxes. And then for men who are older than the age of 40, it's just going to be greater than 2 little boxes, so 2 millimeters. Secondly, there has to be reciprocal depression in the opposing leads. So what is that? That is the other ends of the heart from where the STEMI is occurring. Okay, so if it's in the anterior septal, so that's leads 1 to 4, then you're thinking, okay, well, the inferior leads, okay, so leads 2, 3, and AVF. And this is just a chime in. This was something that was very important to me that I learned when actually I started, not even when I was a med student. It was the beginning of intern year, was that a new left bundle branch block is often considered a STEMI equivalent. So emphasis on the new. If this is chronic, then that doesn't apply. So let's look at that EKG again, okay? In this case, it's showing you an inferior STEMI. Why? So if we're looking here in red with circle, leads 2, 3, and AVF, we do actually see an ST segment elevation, okay? So specifically, if we're looking at lead AVF here, okay? Right here would be typically the J point. It's kind of hard to see, but this right now is the TP interval, and it's 1 box, okay? We can also see that in leads 2 and 3. And then what's circled in blue is the opposite direction, okay? So this is the reciprocal depression as we're seeing. It's the ST segment, instead of being elevated, it's actually being depressed. AVL, and we see in lead 1, there's also this reciprocal depression. So another important concept, however, though, is that there are STEMI mimics, okay? So there are plenty of different acronyms, nonics, anything that you can see. This was a very common one. This was taught to me back when I was an intern. I see this in a lot of different resources, so use it as you will, but it's the concept of elevation, okay? I won't go into the huge specifics of it. You can look at your own time. However, the first 4 are the most common, okay? Let me turn off the clicker right here. So the first one being electrolytes, okay? So most notably hyperkalemia, left bundle branch block, which is also very, very common, early repolarization, and lastly, ventricular hypertrophy. Okay, so what really helps us in determining, though, is this a STEMI mimic versus STEMI? Well, your first piece of tool, you can use the concept of what's concave versus convex, okay? So on the left here, so typically what I would do is that when I'm looking at EKG, I draw this theoretical point here, okay? So what I do is I start off here at my J point, and I draw the line above my T wave, okay? And if it's concave, that's typically a good sign, okay? That typically more is indicative of what we call a STEMI mimic. So it could be hyperkalemia, it could be a left bundle branch block. However, on the other spectrum is the idea of it when it's convex. So now let's look at the typical STEMI, okay? Right here we see at the J point, I'm starting here. I'm gonna draw my line to the top of T wave, and we're seeing here, it's ultimately convex, okay? And that situation is very specific for STEMI. Now, absolutely, don't just simply rely on this. You're going to use multiple perspectives. You're going to look at the patient history. You're going to do the physical exam. You're also going to look at the criteria we just discussed earlier, the concept of two contiguous leads and also the reciprocal depression. But it's just one little piece of information you can use. And then lastly is what we call the modified Scarbosa's criteria. All right. So this was developed by a cardiologist, okay, and basically was for situations specific for a left bundle branch block. Okay. I'm going to be teaching you all the modified Scarbosa criteria. Okay. Why? It was developed by a gentleman named Dr. Stephen Smith. It's also known as the Smith modified Scarbosa criteria. And it basically just adds a little more specificity when you're in these situations. And why is it specifically talking about the left bundle branch block? So I found this image right here that kind of shows the best really example of this. So we're not going to, of course, go into the concepts and electrophysiology of bundle branch block. We could talk about that in the future. But look here, okay? Bundle branch blocks typically have a concept what we call a discordant T wave. And what's a discordant T wave? It's when your T wave, okay, is simply in the different direction compared to the primary wave. All right, so this is going down, and in this case, this is going up. And specifically for a left bundle branch block, because of this discordant T wave, it actually brings up this J point a little higher than typical. Okay, and if you can clearly see, it's more than one little box in V1 in this case. So that could be a sign for a STEMI. All right, so now this brings up the important concepts. So when people have left bundle branch blocks, they can't utilize typical STEMI criteria, which is where Scarbosa criteria come in. And we go into depth, you can look into your own time, but it consists of three things, and all you need to do is achieve one. The first, it could either be a concordant ST elevation. Two, it can be a concordant ST depression. Or lastly, there's proportionally excessive discordant ST elevation, typically above or equal to 25%. Okay, we got through the rough part. Okay, that was the EKG. So let's talk about more of the fun stuff. Okay, so now let's say you got that EKG, or it's another night. Nurse comes to you saying, "Hey doc, can you look at this chest X-ray really quick?" So I'm going to bring to you a really simplified framework that's going to be very useful, more for purposes of during your night shift, or in general any kind of high stress situation. First and foremost, you have to assess the patient. Okay. Why is that? Let me show you a perfect example. Let's say the chest X-ray was stone cold normal. Okay. But when you look at the patient, we're seeing the right here. Okay. Clearly, this patient is tripoding. They more look like they're in respiratory distress. All right. Well, on the other hand, let's say if chest X-ray looks maybe deemed a little abnormal to you, but they're resting. Okay. This is important because it'll change your triage management, ultimately your clinical pathway. Okay. Now let's move on to step number 2. Check lines and tubes. Okay. Why? Okay. Yes, lines and tubes aren't necessarily the most important thing when we're checking an X-ray, but they're often the most mislooked. All right. And they actually provide a lot of information. Okay. So let's start off actually from the far right. What we're seeing right here, in this case, is a port. Okay. And let's say the patient came in. All right. They came in for sepsis. You're currently treating them. You couldn't really find a source of infection. Next thing you know, you look at this X-ray and you see this line here. Well, it can bring up two ideas. Is the patient actually immunocompromised? Okay. Or is it actually the line that could be the source of the infection? Okay. Now moving down to the middle, right over here, this is an NG tube. So when we're looking here, see how it goes all the way down and passes the diaphragm. Okay. Let's see, there's another situation. Patient comes in, they're just persistently nauseous and they're vomiting. What if instead, when you looked at the NG tube, it was right below, right above the diaphragm right here, okay? It shows it actually has an insert into the stomach. So next thing, this patient is essentially regurgitating NG fumes, all right? And then left is just very commonly when you're in the ICU, you're gonna do a lot of different central lines. And it's always important to confirm your placement because ultimately you'll need it to actually administer really critically needed medications. All right, now we're done with the lines. Let's move on to step 3, okay? And this, my personal favorite, is more just the easiest one. Is there symmetry? Okay, chest X-rays, they should be symmetric. All right, and then lastly, is there any white where there shouldn't be? Okay, so the far left here, in terms of the coin term of being symmetric. All right, we can see here how the lung fields go all the way out to the ribs. Okay, well, it should be symmetric on the other end. So now I'm going to go to the right. And as we extend out, the lung fields clearly change right here, and I marked it. This is actually a pneumothorax. Okay. And now looking at the right, which I circled, is more of that, is there white where there shouldn't be? And clearly there shouldn't be white there, okay? It's evidence of consolidation. Okay. So it could be symmetric, it could be evidence of pulmonary edema, which also shouldn't be there too. All right. These three steps alone, you can be able to get through most x-rays, especially for tonight, because ultimately, like I said, you're just triaging. So now let's move lastly to the last concept, acid base fun. Okay. I personally enjoy acid base, but for a lot of people, they don't. Okay. And I don't blame them, might I add. And this is actually a very, very common scenario you might go to. Let's say in the middle of the night, you're currently admitting a patient, everything was stone cold normal. This is a CMP, except for that one notorious lab, and it's the bicarbonate. And might I add, a lot of the times too, when we see a lot of normal labs, we tend to actually mislook the bicarbonate. Okay. So in this case here, it's 18. Is this patient acidotic? Well, we'll find out by the simplified approach. So what I like to use personally is just 4 steps, okay? Step one, kind of like with the x-ray, and how you should really approach any kind of situation, okay, is assess the patient, okay? Is it sick or not sick? Is it something that we're just calculating for fun or something that we actually find is going to change management? Step two, just know about the pH, okay? Yes, bicarbonate might be low, but we need the pH to ultimately determine, well, is the patient acidotic or alkalotic? Step three is more about, well, if they have acidosis or alkalosis, what's the primary mechanism? Is it respiratory or is it metabolic? And then lastly, is there an anion gap? Okay, and bonus, you're going to get hounded on this all the time, whether it's if I was attending, whether it's the ICU, whether it's just for multiple people. It's very important though, but if there's metabolic acidosis, well, what's Winter's formula? And we'll talk about that real quick. But let's say we assess the patient, okay? They look fine, but we still should do appropriate workup, okay? Let's start off with this example. So let's say for that exact same patient that we got the CMP for, let's get a pH, okay? Preferably, if you're just looking at pH, I recommend VBG. It's not painful. You're not really poking someone's artery, okay? Especially not really caring for the oxygenation. VBG should be perfectly acceptable, okay? So we're seeing right here that pH is about 7.26, okay? So less than ideal, all right? So typically it's 7.35, 7.45. Some people might say it's less than that. So is it acidotic or alkalotic? In this case, it's acidosis. So step three, all right, so you have an acidosis, okay? Is it a respiratory or in this case, it's gonna be metabolic? So we have two basically areas. So I'm looking in my far left here, I'm looking at my CAP, I see my bicarb is 18, and I'm looking at my VBG, okay? Or I'm seeing the PCO2 is 34. Well, what makes sense in this situation? Okay, so what makes really the classification of someone to have acidosis? Well, if we look at the bicarb, that's 18. All right, so less than 24, we typically think in this case of acidosis. All right, and if we're looking at a VBG for PCO2, is the PCO2 should it be high or should it be low when you're thinking of a respiratory acidosis? It should be high. Okay, it should be in this case greater than 35, greater than 40, all right? As you see here, it's 34. So what makes most sense? It's metabolic acidosis. Step four, we're gonna be counting for both the anion gap and the bonus, okay, which is Winter's formula, all right? So the anion gap, as you see the equation right here, it's the sodium minus chloride plus the bicarb. We're calculating it, all right? So we have a metabolic acidosis. If we calculate it out, it's 20, all right? Typically, an anion gap of greater than 12 is going to be what we deem as elevated. So in this case, there is an anion gap metabolic acidosis. And what is Winter's formula? Well, Winter's formula gives you what we call the expected PCO2, aka the patient's respiratory compensation. Okay. And I would really encourage you, you'll get plenty of brownie points if this is an equation that you memorize. And it's the PCO2. It's equals the 1.5 times bicarb plus 8 plus or minus 2, okay? And if I see when I'm plugging out the numbers here, it ultimately equals about 35 plus or minus 2, which is 33 to 37, okay? And if we recall, the PCO2 for our patient was 34. So in this case, they are compensated. So let me tell you a quick situation though, why sometimes we want to really explore these acid bases overnight. I'll give you a perfect example. I had a patient actually with almost those identical labs. They are immunocompromised. They had a bicarb of 18. It turns out they actually had euglycemic DKA. They recently were started on a medication called Jardiance, which is an SGLT2. They got sick and ultimately they had DKA, right? So the glucose is completely normal, but that medication is very common for making, despite them being euglycemic, it can cause that phenomenon. So the key takeaways here, okay, it was pretty quick, but at the very least, it's going to equip you with kind of the really high essentials that when you start, ultimately you're going to feel confident missing, not missing really big, bad, scary things. So first with EKGs, key takeaways. So think territory first, details later. So what do I mean by this? Okay, we have a tendency, I myself am very notorious for this. You want to overcomplicate and look really into the nitty-gritty aspects of an EKG, when in reality, kind of like when you're thinking about the different regions of the heart, that's what you look for. You're just looking for an ST segment elevations in those designated regions, whether it's anterior septal, lateral, inferior, etc., and the reciprocal depressions. Don't think about anything else. And if anything, when you look at the patient, if they're resting comfortably, great. Save it for the morning. Next will be the chest x-ray, okay? In this situation, always lines, because we always typically look at. After that, symmetry, and then you can dress everything else. But that typically is all you really need, because again, you're really only caring about those life, really emergencies, okay? Because you're triaging. And then lastly, just acid base. pH system gap. I'll tell you, when you plug in those numbers, if the numbers don't really add up, that just might mean it's a mixed acid base disorder. And then lastly, recognize danger early. If you have questions, okay, you don't ever hesitate to ask your attendings. We're always here for you. And you don't need all the answers. Your goal, again, isn't to really seek answers. And if you find that, for instance, I think the patient might be sick, and when you're really weighing the pros and cons, you start them antibiotics. If you look at an EKG and you say, I think there actually is a STEMI, call cardiology, let your attending know, because in the end of the day, you're caring for the patient, and that's all really that matters. So again, I'm John Arthur. Here's my email. Please never hesitate to contact me. I would love to speak with you all. It's always been a pleasure being part of the ACOI. This is a family, and I wholly hope that you actually find it so too, because trust me, this is the best kind of family that you could ever get. And then appreciate your time. Please let me know. Hope you have a nice rest of your day. Take care.